So now I'd like to introduce Tamara Daly. Tamara is an assistant professor with York University School of Health Policy and Management. She's a member of the graduate programs in Critical Disability Studies and Women's Studies, and her research interests are in the area of aging, gender and health, care work, comparative health policy, and the role of healthcare nonprofits. Tamara, you're going to talk to us. Sorry. Okay. So good. She's talking about what I'd hoped she'd talk about, which is about workplace violence in long-term care.
I'm going low-tech today. I don't have a PowerPoint presentation. And I'm going to try to be intentionally provocative. My title is Crash Test Care Work, Violence in Long-Term Care Facilities. I'd like to acknowledge the work of my fellow researchers. Pat Armstrong is the principal investigator on the study. Hugh Armstrong is also a member of the team, as are Albert Banerjee, Sterling LaFrance, and Marta Zebahelli, who is from Sweden. The study I'm going to be talking about today was funded by the Canadian Institutes of Health Research, as well as Pat Armstrong's chair. She has a CHSRF, CIHR chair in nursing and health research. Okay, so crash tests. Crash tests generally involve creating the worst possible conditions to see how the body and the vehicle can withstand the pressures. I want you to imagine something a little unconventional. In this short talk, I want you to imagine that the long-term care sector has been set up like a vehicle crash test course. The workers and the residents are in the car together. The environment, in other words, the conditions of the care, are the impossible road conditions, the lack of airbags, improper seatbelts, and poorly tuned brakes. When the vehicles inevitably crash, both the workers and the residents are hurt. Bodies move in space, experiencing impact, crash, pain, stress, fear, and injury. I argue that care workers in Canada are in situations that resemble crash tests. There is lack of support, resources, materials, and time. They are expected to care for our most vulnerable citizens in conditions lacking in adequate supports and resources. Our research has been guided by several assumptions. The first is that the conditions of work are the conditions of care. The second is that people doing care work are excellent sources of information about care and the conditions of their work. And the third is that we understand healthcare as existing within a political, economic, and social context. In 2005, Pat and I first conducted an initial survey of Ontario's care workers, and then we subsequently, with the larger team, conducted 2 parallel comparative surveys. So we were part of the Canadian team, and Marta Zebahelli led the Nordic team. We were exploring long-term residential care in 3 Canadian provinces as part of the Canadian team, so Ontario, Manitoba, and Nova Scotia. And Marta Zebahelli was responsible for the Nordic component of the survey, looking at Finland, Norway, Sweden, and Denmark. In addition, in Canada, we conducted 9 focus groups, and we asked participants in our focus groups literally if the survey results reflected their experiences. So we went back, we took our survey results, and we asked them to comment on the results of our survey. So in this way, our study used a mixed methods approach. We combined qualitative and quantitative methods to provide an opportunity for me here today to reflect on each method's differing and mutually reinforcing contributions. So long-term facility care includes dwellings for chronically ill seniors and for people with disabilities who need both medical and social supports. Women comprise the majority of direct care workers, most of whom are unlicensed personal support workers, or care aides, as they're called in Sweden, and I'm not going to try and say that in Swedish. Varbeträd. Marta's not here, I can't do it. There are a few dietary workers and housekeepers, and fewer licensed or registered nursing staff and therapists per facility. At present, as in the past, there are far more women than men living in long-term care facilities. The majority of the jobs are low pay and low autonomy, what Karasak and Thorell refer to as high demand, low control, and low support environments. There's a lack of value placed on caring, which is generally regarded as women's work, and an overt focus on breaking down caring into individual tasks, ignoring its important relational aspects. Despite the highly gendered reality, analyses that account for this context are rare. Long-term care is largely a unionized work environment in both Canada and in the Nordic countries, with about 8 in 10 workers belonging to one. The projects described below reflect the responses from unionized workers, who typically have more job security and wage protections than their non-unionized counterparts. The resident populations in both sets of jurisdictions are similar. Women are the majority of residents, and residents exhibit nearly identical rates of Alzheimer's and dementia. Despite these similarities, the violence reported in Canadian long-term care homes is ubiquitous and persistent compared with much lower levels reported in the Nordic countries. This led us to question why, given the similarities, is violence more pervasive in Canada? And we came to the conclusion, even though Canada is a gold medal winner in hockey, that this was not the reason. Almost 8 of every 10 workers reported that their workplace was short-staffed due to people who are sick or on vacation and not being replaced. And this is in Canada, while over 1/3 of workers reported that their workplaces were short of staff due to job vacancies on a daily or weekly basis. Some personal support workers describe fellow workers as, and I quote, sick, stressed, and burned out. They note that the normal work week is usually 4 days, not 5 in a row, as there is too much burnout when people work too many days in a row. Canadian workers also reported that they work with more residents per day than their Nordic counterparts. For instance, Canadian personal support workers reported working with an average of 32.7 residents per day, while the Swedish care aides worked with an average of 8.8 residents per day. Likewise, Canadian personal support workers were twice as likely as their Swedish counterparts to report that they, quote, had too much to do almost all or most of the time. So it was a 60% in Canada compared with 36% in Sweden. So in terms of the violence then, we call this structural violence, and I'd like to talk about how we came to understand this as structural violence and how it was made visible to us. Violence in these facilities is much more than the physical and psychological interactions between two people. In trying to understand the issue of violence, our first Ontario survey focused on the prevalence of resident-to-worker violence and resident-to-resident violence. So that was the first survey. Our results showed that violence is common and occurs frequently within long-term care homes, and for those of you that work there, I'm sure that you'd agree with me. Our results showed that violence is common and occurs frequently, and almost all workers, a total of 96.3%, indicated that some type of violent incident had occurred in their facility in the previous 3-month period. In fact, the majority of workers, almost 55%, reported that some form of violence occurred 11 or more times in the 3-month period preceding the survey distribution. In total, over 80% of workers indicated dealing with one or more residents violent toward a co-worker. In the first Ontario survey, nearly 10% reported daily incidents of violence. When we asked about violence a few years later in the follow-up survey, in the Canadian survey, just under half, so 43% of personal support workers reported almost daily experiences of violence. So almost half of the workers reported almost daily experiences of violence. But the rates of violence reported by the Canadian workers are much higher when compared with the Nordic countries, which averaged only 6.6% of workers reporting experiences of violence more or less every day. During the focus groups, we reiterated the Canadian survey's results and asked workers, does this reflect your experience? Here is where the unexpected story emerges. The workers recounted stories that made it clear violence was a persistent and even expected part of their work with seniors. And I'd like to note now, without having the numbers for you to reflect back on, that it looked as though in our second survey that the report of violence had gone down, and we were surprised by this finding. So when we asked the workers what was going on, they made it clear that violence was a persistent and even an expected part of their work with seniors. In some cases, it appeared so normalized, in other words, so routine, that many excused it as an ordinary part of their everyday. One woman notes how, quote, if it happened on the street, we would report it because we take it for granted that the person on the street knows what they're doing. When it becomes seniors in a long-term care facility, they might know what they're doing, but they're senile, and we've been told it's part of our job. Workers report then being subjected to daily physical violence, such as scratching, kicking, spitting, swinging, and pinching. And one woman told us, somebody's always got a bruise or a bump. Another woman told us, I've been punched in the face several times. I've been punched in the jaw several times. Getting hit, having your wrists twisted, that's the big thing. They're constantly twisting your wrists, pulling and shoving at you. I mean, that's a day-to-day thing. I work on the locked unit. Violence is an everyday occurrence. Following Stewart and Makwarimba, they note that using qualitative and quantitative data sometimes produces divergent results. We found that a clear majority in our survey report that they either never or less than every month received unwanted sexual attention by a resident or their relative. So it seemed as though the majority of people said, no, we're not getting unwanted sexual attention. And workers also in the survey reported that they were infrequently the recipients of racist comments by residents or their relatives. But by contrast, the focus group respondents reported, quote, constant and unwanted sexual attention, including verbal, physical, sexual, and moral violence and assault. Violence is frequently unacknowledged, and its impact is also frequently diminished by managers. This quote by a personal support worker provides a good example. Quote, he's just an old man. He's 97 years old. What can he do to you? Well, you're a big girl. Nobody can bother you. Lighten up. Another worker noted, residents have all the rights, and when it comes to staff being abused, nothing is being done about it. What about our rights? The written comments and focus group responses revealed how workers normalized their experiences of violence, particularly in light of a lack of management support or acknowledgement. In this way, violence is an invisible, and accepted part of the job in Canadian long-term care facilities. This is supported by an analysis of the Ontario Provincial Dataset that reports on problems in long-term care homes. It contains 611 complaints between 1996 and 2007, but there are no resident-to-staff cases of abuse, supporting our finding that violence against workers often happens under the radar. But this is not the case in the Nordic countries, where caring is more readily valued and working conditions are far better. In these countries, where there is a lower staff-to-resident ratio, in other words, staff are working with fewer residents, where baths are more frequent, and there is more time for everything from chatting to toileting to caring, the reports of violence are far, far less. Our use of an iterative approach, literally asking focus group participants if the survey results reflected their experiences, opened workers to elaborating on our results and telling us personal stories that became key in our interpretation. Without this mixed method, we could not have learned how violence was experienced, normalized, and resisted by Canadian workers. It was important for us to ask ourselves what the numbers reveal and what they conceal. We would not have understood long-term care if we did not use the survey. We would have missed some of the important numbers that describe the context of care, such as the average number of residents cared for by each worker. But without the focus groups, we would not have known that workers are expected to limit their use of incontinence products, for instance, contributing to worker stress and creating a site of worker resistance, or that workers' experiences of violence were routine to the point of being invisible. We would have missed the ways in which violence is a result of poor working conditions that impinge on these workers and affect the ways in which they negotiate their work. The key finding of structural violence emerged through this iterative process, which enabled the numbers to make sense and identified important patterns. Further, the qualitative component contributed surprising insights for addressing structural violence. So this study provides a compelling illustration of how mixing qualitative and quantitative inquiry can contribute to struggles around basic human rights, such as the right for workers to care in safe conditions and for seniors to receive quality care. Violence in these facilities showed itself to be an important and persistent theme. Lessening the conditions that allow violence to flourish are a key issue that policymakers, unions, workers, and employers must address. Improving conditions for residents and for workers in long-term care homes is a necessary first step. The metaphor of a crash test for long-term care is an apt one. Cars are on a path that is constructed to lead them towards a crash. They are tested through a series of conditions and put under enormous pressure to perform. Inside the cars, there is an obvious lack of proper supplies. There are not enough airbags, and the brakes are not working optimally. The bodies and minds of the workers and residents inside of the car are placed into positions that create ill health, injury, and the experience of violence. So our challenge, what can we do to improve the working conditions, thereby improving caring conditions in long-term care? Thank you for your attention.